When you wake up in the morning, it's 1:45, and you want to have a little fun. You brush your teeth, you brush your teeth. When you wake up in the morning, it's 1:45, and you want to find something to do. You brush your teeth.
Visuals, and we need to come together as a team in order to make things work. You know, being a dentist, being a periodontist, I can't do what I do without having an assistant, without having a team of hygienists, without reception as well. So the idea is that I want to basically get together just to discuss certain things. You guys can't see coming by, I won't bite anything. So my name is Herman Thang. I'm a periodontist. I did my training down at the University of Toronto. All those fancy things, basically a dental degree, that's the perio degree, that's the certification for the Royal College, and that's the American certification as well. So next screen, somebody will push the button. So basically this is just an overview. I don't expect this to be like an intense course or anything. I try to purposely keep it short. And I'm going to hit a number of things, and if you have any questions, there's small groups. If you guys want to, I want to do this more of as a dialogue, so if you have any questions, feel free to ask. I don't want to be giving a presentation, I want to be having a conversation instead. So basically, all the information is actually on my website, burlingtonperiodontist.com. Log on, all the forums there, all the information is there, all the photos are there as well. Okay. So basically, what do I do? What is a periodontist, and how can I help you guys do what your jobs are? I'm a dental specialist, and I work with the tissues around the tooth. Perimeter, peri, it's basically anything around, and dental is basically the tooth. So I deal with the gums in terms of any recession, any bone problems, any dental implants. Dentists, you guys do everything else with the tooth. I do everything around the tooth. And my role, in addition to what the gums do, gums and me, we basically support what everybody else does. It's basically an extra 3 years of training after dental school, and you know, the important thing is that I work with you guys to try to help. And thanks. So basically, starting off with the basics, gum disease. There are classifications with these. There's something minor, which is a gingivitis situation. That's what the hygiene team, that's what you guys deal with on a daily basis. It's hard work. It's not easy. It's all manual labor. Your hands, your neck, your eyes are going to be strained by the end of the day. But what you guys do is you guys help to maintain everything, and the majority of your patients need you. And that's your task. When it progresses, gingivitis is there, you can't have periodontitis without gingivitis. Periodontitis is when you actually get bone loss around the tooth. That's when you actually start losing the gum tissue. That's when you start losing the bone as well. As you can imagine, when you have a shaky foundation for a tooth, the tooth can actually become loose and end up in tooth loss situations. Before it even gets to that point, you want to be able to identify them. You want to be able to try to treat them as well. Okay? And the main task of the dental team for the hygiene, for the recall, is to try to monitor and maintain these issues. So how do we check for these? What do we need to look for? And what we need to look for is similar to a case like this. When you conduct your normal exam, you see the teeth, of course. You see, you know, any large gross caries. Try to help the dentists when they come in to check to identify these things. What are other things that you need to look for? How I usually conduct my periodontal exam when I do a full comprehensive exam is, of course, I'll go through and chart which teeth are there, which teeth are missing. It's very basics. From there, what you need to do is go around for every single tooth, check the amount of recession. We'll define recession a little bit later on. However, what you need to do is you need to identify where the CEJ of the tooth is, where the enamel meets the dentin. You also need to figure out exactly how much attachment loss you've had by measuring that space. Anything that's of concern, just bring it up to the dentist or the dental team whenever you're around. So what do you guys see in this situation? Would you call it gum disease? Would you say it's healthy? Does it look pretty good? Just first glance, I'm not giving you all the information.
It looks generally healthy with some areas of recession.
Yeah, exactly. It looks fantastic. It actually looks pretty great. Is there a lot of buildup around there?
No.
Can't see anything. It looks pretty healthy. The other things you need to look for, of course, with the full exam, you also need to do the probing. You actually need to physically go around and measure every single tooth in every single spot. When you're doing a full periodontal exam, you're looking for anything that might be deeper than a 5. 5 and deeper is usually the cutoff for any types of involved periodontal treatment. Anybody know the reason why a 3 is healthy, why a 2 is healthy, or why a 1 is healthy?
Because the deeper it goes, that's it worse. Shouldn't go like that.
Absolutely, but why though? Why is like a 3 healthy? Why is that an
That's just the
arbitrary
general
cutoff?
norm, is the average norm is up to
But
3.
why? Like dentists, you guys know?
Yes, why is it 3 or 2 or 1?
That's right.
It's easier. That's the size of the sulcus.
There's actually a large variability in sulcus, but you know, cleansability is one issue. And if you're unable to clean it, studies have shown that once the pocket gets to a 5 or a 6,
Well, it's like lint in your pocket.
You got it.
Take it out.
that's a good way to put it. That's a good way. The studies have actually shown that once the pocket gets to around a 6, scaling it closed, you're only around 11% successful in removing the calculus. So you fail 89% of the time. So once it gets to that point, we're in trouble and there's other things we need. If you want to go to the next screen, oh sorry, before we move ahead, you need the probe. You need to double check everything. You need to measure it. Anything that's deeper than the 5, bring it to our attention. Anything that bleeds as well. Bleeding is a good indicator, or the absence of bleeding. When you poke the area and there's a bleed, it gives you an idea that it's actually stable. It's around 98% positive predictive value of actually being stable. If there's actually deep probing, there's bleeding, that gives you an idea there's active inflammation that's going to fall apart. Other things you need to check on are mobility as well. So as you can tell, it does take a little bit of time, but at the same time, you do need to check these things. Because that healthy case, as you can see on this x-ray, this is actually the same guy. Even though it looks healthy, there's no buildup, everything looks healthy, you can see that he needs an extraction of at least 2, if not 3 or 4, even all his molars. So even on the surface, when it actually looks healthy, there is disease happening, there is buildup, there are very serious problems. You never really want to get to this situation. So it's important that you do check the mobility. Well, start from the beginning, check to see what teeth are there, what are missing, the recession, check the furcations, check the probing, check the mobility. So these are all things that we need to double check. So that's just periodontal disease. Dr. Afif, if you don't mind, there you go. Okay, so another topic that we wanted to talk about is recession. What exactly is recession? Well, we touched upon it briefly earlier, basically from the CJ, the measurement to the free gingival margin. It's an indication of exactly how much support you've actually lost for the tooth. And it's a situation where you've lost a little bit of gum tissue, lost a little bit of bone tissue as well. Possible causes of it, 2 main causes, multiple causes. 2 main ones are in this city, in this area. Number 1 would be a toothbrush trauma. If you've abraded the gums, the patients have been brushing very aggressively or using a medium or hard brush, you can actually end up with a lot of recession because of that. The problem with recession is that if the damage is done, it never grows back by itself. Once it's gone, it's gone. You can't stimulate it to come back. It's just unfortunate when it does happen. The other thing that we need to double check, the reason why we need to check the probing and make sure that the mobilities are normal, is that it could be a sign of periodontal disease as well, such as the previous gentleman. He did point out there was a lot of generalized recession. The reason that he did have the recession, not because of tooth trauma, but because of the fact that he actually had severe bone loss. Main concerns of patients with recession are aesthetics. It's like if they have an effect tooth, like it just doesn't look right. You know, the yellow part of my tooth is starting to show. I'm looking long in the tooth. Another possible cause of it is, or symptom, is sensitivity. Certain things such as temperature, hot, cold. You don't want to eat anything sweet. And the other thing you need to watch out for is progression. These are the 3 things you should be watching out for. Progression is basically it's getting worse over a short period of time. 1 month goes by, it gets worse. 2nd month goes by, it gets even worse than it was before. So those are 3 indications for actually treatment, urgent treatment. Classification of recession defects is basically levels of severity. As you can tell, class 1 situations are much easier to treat than class 4 situations, even class 3s. It will go over the diagnosis, and I won't get you to read the table. I'll just walk you through it. So for instance, class 1 recessions, class 1 and 2. You can clearly see in this case, this is actually a nice case in the sense that you can see exactly where the root is. You can see exactly where the tooth starts because he's got a little bit of discoloration. And this is a class 1 situation where he does not have any bone loss at all. And he's got plenty of nice keratinized tissue. We'll touch upon keratinized tissue later as well. These are situations, this is a class 1 situation where we can treat it, we can actually add gum tissue to these areas, and we can do it predictably as well.
Oh, the money is just in the first drawer.
Where?
First drawer on the reception part.
Hello?
So as you can tell, this is the post-op. This is actually 2 weeks after, and you can see that he's actually healed very nicely. The part of the root that is exposed has been covered on both the teeth. The important thing here is to mention is that he's got 0 bone loss. And the classification of Miller class 1 or 2 defect is that there's absolutely no bone loss. These cases are actually relatively treatable. provided that they don't progress to a class 3 or 4. Show another couple of cases here. There's another case where he's got recession on the 3 teeth, the lateral, the canine, and the first premolar. And the post-op, this is actually 2 weeks. What these graphs should look like at 2 weeks' time is that they'll be red, they'll be a little swollen. It's early in the healing process. Gum tissues, how long does it take for it to heal, for it to fully mature?
6 weeks, 3 months.
Yeah, those are approximately anywhere from 4 to 8 weeks. In this situation, it's been 2 months, so when the grafts come back, this is exactly what they're supposed to look like. The important thing is that we realize it's not infected. If it was infection, usually there's a little bit of pus, there's a little bit of an odor, there's a little bit of discomfort in the area. This is actually within normal. You can see that we actually got very nice coverage on the roots. These are treatable cases. Next. Miller class 3, class 4, these are classified as cases with recession, with bone loss. You can tell that not only on this canine, but on the majority of his other teeth, he has recession. Yes, he does. Is this something that's urgent, that needs to be treated, needs to be grafted? Well, you also have to identify the fact that he's actually lost a lot of bone due to periodontal reasons. And unfortunately, this situation has gotten to the point where, because there is bone loss, even if we do attempt to graft it, it's not predictable. So the idea is that we want to be able to try to catch the cases early when there is recession without the bone loss, because those cases are treatable. However, when it gets to the situation where there is severe bone loss, you can refer it for recession. However, there's not much I can do to try to help in those cases. Okay. The other case is a definition of a Miller class 3. You can see in this case, there's actually no bone loss around this tooth. The patient actually had ortho, and it's got severe recession on the canine. And it also tells actually there's no keratinized tissue towards the tip of the tooth, as you can see here. This is actually a Miller class 2 defect, because there's no bone loss and it's recession to the mucogingival junction. Is this treatable?
Yes.
By what I've told you, I've kind of misled you. Yes, it should look treatable because of the fact that there's no bone loss. There is recession, yes. However, if you go to the next photo, this tooth is actually completely malaligned. As you can see in this photo, you can see the nice arch of the teeth. The tip of that tooth is actually a nice position, but if you look at the root of it, you can tell, I don't know if you can see from that angle, but this tooth is actually completely, the root of it is completely tipped outwards. Because of the malposition of this tooth, because it's completely tipped out, there's no bone on the outside of that tooth. Hence, it's actually Miller class 3. There's no bone on the outside of the tooth. Therefore, it's not predictably treatable, unfortunately, without pulling the tooth back in with ortho.